oh, you have a baby? You're not going to sleep for years. And it's 100% not true. And the fact that you're feeling sad or anxious or angry might be just a normal human reaction.
Look for The Helpers, a podcast by Engage Therapy in Agoura Hills, California.
So I want to welcome you to our podcast. This is Dr. Brittany Booth. She's a reproductive psychiatrist here in Westlake Village, and has become a friend and colleague of ours. And I'm just really excited to have you here because I've learned so much from you.
I'm so excited to be here.
Thank you. In the short time that I've known you, you've taught me more about my own body and the people around me, and it makes a huge difference to understand what's going on. Number one, to understand that when to worry and when not to worry, and also it's so refreshing to have a doctor who really focuses on women's health and the way women are. Because many of us, including myself, have had a lot of experiences where maybe I feel misunderstood or not taken seriously. And it's quite refreshing to have somebody who is like, I feel like you're a real advocate, not just a piece of knowledge and you share your knowledge, but you also advocate. And I think that is so awesome. So, let's see where the conversation leads us today. There's a lot to talk about. But I'm just excited to sit with you, as I always am. And I know you are trained at UCLA.
Yeah.
And you continue to work there at a really cool program that I also want to know more about. But let's start with the basics, because I feel like, the term reproductive psychiatrist, I didn't know what that meant.
Not a lot of people do.
Don't. Yeah. So would you mind just starting there so our listeners can understand where you're coming from and what your specialty is?
Yeah. I mean, I'll even just start with that, like the difference between psychology and psychiatry, right? Yeah. So psychiatrist is a medical doctor that prescribes medication. Sometimes we do a little bit of therapy, we throw in therapeutic techniques, but, at least in my own practice, I kind of stay in my medication management lane, to treat mental health conditions. And that's because...
Which is a big lane.
It's a big lane. And I did get some therapy training and I do incorporate, some techniques, but I just know that, there are a wealth of much better trained, amazing psychologists around who are much better able to do that work. So,
the cool thing is to work together.
Exactly.
That's
and collaborate.
When we thrive, yeah.
Yeah. But even in med management, like you said, it's still a big lane. And so reproductive psychiatry is a subspecialty or a niche of psychiatry that focuses on the intersection of hormones with mental health. Yeah. And then, women's mental health is sort of, related, but not quite the same thing, because reproductive psychiatry can also incorporate, hormones in when folks are transitioning genders, right? But women's mental health, which is what I really focus on, is what is the mental health and the experience of mental health of women specifically? Like, what does it mean to be a woman in this country, in this world, in this society? And treating mental health through that lens, because something that might get pathologized elsewhere just might be, you're just a woman and there are things that are working against you, and the fact that you're feeling sad or anxious or angry might be just a normal human reaction, right, to something that's going on.
Yeah, which, by the way, just that, what you just said, is I feel like is so corrective for so many women, to give permission for the fact that, yes, we feel those feelings, but society kind of
just be quiet.
Yeah.
Postpartum rage, I think, is one of the best examples of this. Is it's a chief complaint for a lot of people who come to seek treatment for it. This is something that's wrong with me. I need medication, or I need help with this. And sometimes that's true, right? When it gets to a certain severity, or if it's coming out in physical behaviors that are unsafe or whatever. But a lot of the time it's just, oh no, you're just expected to handle way too much, manage your emotions and the emotions of everybody around you, have a complete lack of support, both from, your own relationships and just structurally, societally, and you're angry about that, you're just paying attention. You're a alive, breathing, aware human being.
Yeah. I mean, I can tell you from my own experience that I experienced postpartum rage, but I didn't know there was a term for it.
Yeah.
I just thought exactly that it's just all these other things. And when I learned there was a term for it, it's like it turned everything upside down. It turned my experience upside down. Like I had to rethink about my experience.
Yeah.
Because it was not till way later that I learned about that term.
Yeah.
Which is, it's really something. I'm in this field. Like I'm aware. I am like I keep up with things. And I did not know about that until you told me about it, actually. Or maybe I saw it on your Instagram.
Oh, maybe.
It's possible that that's the first time I like really understood what was going on with me. But this was years after the fact.
Yeah.
So I had to like replay it all and try to understand what was going on.
Really, yeah.
Yeah. So, and I just think so many women, when you're in it, there's all these reasons that we could come up with. But what about just the fact that that's your situation and it's reasonable to feel those feelings?
Yeah.
So that's like permission that I think people need. So a lot of women come to you postpartum. What about also before, like trying to get pregnant or just no pregnancy related, just coming for hormone issues? Like how does someone know they need a reproductive psychiatrist versus a regular psychiatrist?
So reproductive psychiatrists really come into play when there's reproductive transitions or hormonal transitions. Okay. So we think about the menstrual cycle, right, which is just this monthly cycle of hormonal transition, right? And some people struggle with their mood in the time leading up to their period, right? There's a disorder called premenstrual dysphoric disorder, which is essentially a really very severe version of PMS where their relationships or their ability to work or, ability to function is actually impaired. So that's a disorder that reproductive psychiatrists treat. The perinatal period, right? And that can include conceiving. If you're going through fertility treatment, you're getting hormone treatment, right? When you're pregnant, your hormones do all sorts of fun things.
Yeah.
When you're postpartum,
same
exact thing, right? Your hormones during pregnancy are rising steadily, and then literally in a matter of days just drop off a cliff. Yeah. And so the postpartum, and then they have to recalibrate, re-regulate. And then we also think about menopause, which is another huge time where hormones are changing. And all of these various times can affect mental health, right? There's, studies that absolutely show that women or people who are assigned female at birth go through, these different transitions, and they're at much higher risk for mood disorders.
During the transition times?
During the transition times. So there's really interesting graphs that show, young kids, like up to age 10 or whatever, the risk of depression is essentially the same between girls and boys. Like the lines on the graph completely overlap. As soon as you hit the time of puberty, they split. Really? And then until the time basically of menopause, like 40s, 50s, the line for women is just consistently higher than men, and it spikes around perinatal period. And then right around menopause, it kind of starts to...
I mean, I think that makes sense.
Yeah, exactly.
Having been pregnant twice and, just going through monthly changes, I think that makes sense. But why isn't this more common knowledge?
It gets...
Or talked about
minimized.
more.
It just gets minimized, right? Oh, it's just hormones. You're just being crazy. It's just hysteria, right? You name it.
Do you think that it's like a way to just get, because I think, okay, this is going to become, who knows where, okay. I have so much to say, but there's society, right? And we're part of society. Women are in society. So I wonder how much do we contribute to that exact thing of, oh, well, it's just this, I'll get over it kind of thing.
We're very much, well, part of it. Yeah, we are very much culprits in this too, right? Yeah. we do it to ourselves, and we can do it to other women too. We can demonize other women who are struggling or who act differently or who are louder, more out of the box, more vocal, right? It takes a lot of conscious effort, I think, to, in your own life, shrug off that tiny little box that we get put into, and to recognize when we're doing it to other women, and to stop doing it to other women too. But we can very much be the creators of our own, misfortune and suffering.
Yeah, and I'm thinking about, like, when does that start? I have a daughter. She's in elementary school, and I was thinking about this the other day. Like, when am I supposed to expect her to get her period? When is this gonna, when does that narrative start? And how am I playing into it? And how can I stop playing into that?
I mean, it does start. It's so early, right? I have a daughter too, right, who's also young, elementary school age. And I'm always trying to notice, when she's being loud and absurd and crazy, to not diminish that, to encourage it. And to me, at this age, it's coming up so much in terms of the conversation about body image and size. And I'm so much more aware of comments that are made that she's hearing, even if it's not directed towards her. Right? Like, family members in her life have recently lost a good amount of weight, noticeable amounts of weight, and they're getting healthier. They're doing it, to be healthier, which is wonderful. But she's hearing the congratulations. Oh, you look great. You lost all that weight. Wow. Right. And that narrative of, like, oh, smaller is better. Thin is beautiful.
Yeah. But there are ways, because I hear you, and I have the same thing. And I feel, because working with kids, I've worked with kids for a long time. And I feel like what the narrative that you put around that as a parent can really make a difference. Like, give context to why is this a congratulations for this person?
Yeah.
What does this mean for them, so that it doesn't, exactly what you said, it doesn't extrapolate to thin is better. Like, there's a lot of context that can really help a kid to digest what they're hearing. Because you're right, they're gonna hear that anyway.
Everywhere.
The part of thin is best, they're gonna hear, that's coming down the pike no matter what.
Yeah.
Unfortunately. But it's these pieces of, instead of saying, like, going on a diet, you could say, I'm eating things that my body needs and doesn't. I'm not eating things that my body doesn't need. There's, like, just very simple ways, but I think it's really hard.
It's so hard. And even, now being pregnant, right? My body is significantly changing.
Yeah. Oh, yeah. So the conversation around that.
Yeah. When she started really noticing my belly, and I, started to really show, she was like, your belly's getting so big. And everybody, she said it in a setting where there were other people around, and everyone else was, like, laughing, like, oh, how offensive is that? And I had to be like, yeah, it is. That's what it's supposed to do. I'm so happy that my belly's getting bigger. That means baby's healthy and growing.
Right.
And again, just being on top of it, like, okay, this is a really important moment.
Yeah.
Let's frame this correctly.
And what you say matters more than what everyone else says.
Yeah.
Even though kids don't always admit that, but it does. Because when I was pregnant, and my daughter was asking me a lot of questions about that, like my body changing. And to be honest, at the end there, I was huge. And I felt uncomfortable because of it, because that was what was supposed to happen.
But it's uncomfortable.
But it was uncomfortable. But I had to be very thoughtful about the words I use to describe my discomfort,
Yes.
Because I didn't want to, and I also didn't feel good being, like, none of my clothes fit me. Like, all the things that, given the context, was very, very fine. I was very fine with that. But I was aware of, I didn't want to say, like, I'm upset that, I'm so big, or I felt like a whale. And I remember one time being like, don't say that out loud.
Yeah.
Because that's not the message, right?
Yeah.
But I remember thinking it. And so when you have a kid listening, girl or boy, by the way, I believe.
Absolutely.
We just happen to have girls, but first, both of ours happen to be girls. But if I had a son and I was pregnant, I would say the same thing. It's just, I think I'm more aware of it because I just think girls get this message no matter what.
Yeah.
So anyway, how did we get off? We got a little off, but I think it's all related to this conversation about how do we say these things? Why are they not talked about more? I'm so glad you talk about them so that it can be more just known. And then the postpartum period being really also, I think, an unfortunately lonely time. Like it doesn't need to be, there's, especially out here, there's actually a lot of community out here. Most people are here because so they could have kids and raise them.
Yeah. And yet we're so isolated as moms here.
Yeah, there's a lot of stuff. There's Mommy and Me's, there's classes, there's park meetups. We have our Mindful Beginnings class now, partially because of this, because we realize that, there's a lot of stuff that people can connect, but it's that deeper connection that I think is missing, like that vulnerability.
Yeah. And I think for moms who are in the postpartum, who are feeling overall pretty well, a lot of those settings, the Mommy and Me groups and the library groups and things like that, it's a wonderful place for community. The like Moms Who Walk or like Fit Moms, right?
Yeah.
It's women who kind of are like feeling the same way and have it feeling well enough to get out of the house and get their babies out of the house and all of that. I think it's the experience of moms who are really struggling, right? We know 1 in 5 moms will suffer from postpartum depression or anxiety. And it's really hard for them to get out of the house and engage in these groups and activities. And even when they do kind of force themselves to get out and do that, being around moms who are well.
That's what I was just going to say.
Horrible.
I was just going to say that. Even if you're at these, because I was there. I was just there. I'm kind of coming out of it now. I have a toddler instead of an infant, which is its own thing. But I actually don't know that everyone who shows up to those that is acting like they're fine, I don't know that everyone's fine.
Yeah.
I actually think that there's so many people that just white knuckle through, and you think, maybe their hair is done and they look beautiful, but maybe on the inside they're really hurting. And I think because that's what I mean, that there's not a lot of room for the disheveled mom in the corner crying, needing help. So I always say this, I'm curious what you think, and I can't remember if I've said this to you, maybe I have, but my grandma used to tell me, because she had a lot of kids, like 7 kids in Iran.
Wow.
Back in the day. And she was not living in a village. She was like in the city, but she used to tell me like when she was little, she had like a bunch of siblings and she was the oldest one. So she helped raise all of them. So this is like a couple generations back. They were in like a village in Iran. This was before when she was a kid. And she would say that all the women would have, the women would have the babies, but then all the women would take care of all the babies and breastfeed each other's babies. Like it didn't matter who, it's just the baby crying and I have milk and I'm going to feed that baby. And you're going to do the same and so on and so forth. And we're all just going to do this thing together. And the men are going to go do whatever they're going to, work or get the
whatever.
Yeah. But it was this like women helping women all the time. And I remember her telling me these stories and just sort of like, it seemed so like a land far away, Yeah. And then even for her, she was in the city, but she would say like, oh yeah, like I remember I met this guy who was like an uncle or something. And she's like, oh, I breastfed him. Like, and I'm like, what? That's weird. But it's not weird. It wasn't weird.
It wasn't weird.
For her and for them at that time, that was her little crew, her neighbors. She said they were like my neighbors. Yeah. And we just all helped each other's babies, and it didn't seem like it felt alone. It felt like they had each other's backs, and we have gone away from that. And it's really upsetting to me because when I was in that postpartum period, and even still now, by the way, I would do anything to have a setup like that.
Oh, yeah.
Because there's something that like another mom can understand that is unspoken. You don't have to ask. It just is. And I wish we could just, I'm just saying that out loud, I guess, just missing those days.
I know.
Even though I never was a part of those days. But how can we simulate that or get like a version of that back, you think?
I mean, I think it starts in local communities like the one that we have, right? I mean, you may not live on a street with however many other women who have babies the same age, but we live in a community where this is a family community, right?
Yeah,
and
people come here to have kids.
Yeah. And so, you know, those meetups and those groups where you can get together and you know, be with each other, moms can feel seen, babies can feel taken care of. I think, you know, sometimes in these groups, if you can kind of build a cohort, you know, almost like a COVID pod, right?
Yeah.
Where it's like the same people over and over, right? You build that trust, you develop these deeper relationships rather than like a group that you drop in once in a while.
Exactly.
Because then okay, like if that person comes and picks up my baby, if I've met them once or twice, you know,
Right.
what are you doing?
Right.
But if it's somebody that you have really gotten to know, that you've really developed a relationship with, absolutely, right?
Yeah.
My best friend and I kind of, just as a tangent, we have this dream of getting like basically like the Kennedy compound, not necessarily Hyannisport, but just like let's have a compound and just live that life, right?
I have the same dream with my friends.
Yeah, because that's what's missing.
Yeah.
And sadly, what's replaced that is social media, where everyone has a completely different opinion about how to parent and how to do it right, quote unquote, major air quotes, right?
Yeah.
And it's like simultaneously, you know, you feel more connected to more moms than ever before, but also so much more isolated.
Exactly.
And judged.
Yeah.
Right.
Yeah. Because and then you see, you know, I can tell you right now, like just scrolling and seeing, oh, everyone looks so perfect and everyone has this together. And here I am, the mess in the corner, trying to just like, you know, find my shoes. Like that is what social media does.
And even if, you know, especially when it's your first kid, right? And you're figuring this out, like, how do I keep this kid alive? How do I keep, you know, how do I do this?
Yeah.
The way that I want to raise my kids. You just go and you're scrolling through social media and you see one voice saying, you know, use formula, it's great. You know, you need to take care of yourself. And the next video that you see is people who use formula are evil. Breast milk is the only thing you should ever feed your child. You should breastfeed until they're 5, right? These two people are saying exactly the opposite things and
then
have the strongest opinion, right?
Yeah.
And how do you choose which voice to listen to? And it's not just feeding methods, it's sleep training, it's which toys to everything.
Yeah, and sometimes it's not a choice. So then you have that piece where it's same thing with birthing, like C-section or, you know, vaginal or
medicated
epidural,
or unmedicated.
exactly. And there's all this opinion, you know, if facts and information are great. I do love that about the internet, like, right? We know more easily. And sometimes because you know more, it can be a little bit more to sort through, which is fine if you're sorting through it yourself.
Yeah.
I think it's really hard when you're sorting through other people's, you know, opinions and everything. You know, I mean, that's an interesting point. I didn't think about it like that because you're right. If it's the middle of the night, like with my first, I didn't scroll as much in the middle of the night when I was up with her. And then with my second, it's unfortunately more of, it's more in the fiber of like, I don't want to say who I am. That sounds really bad, but
it's more habit.
I'm more in the habit of it this like 7 years later.
Yeah.
Which is disturbing. It's actually really upsetting, you know, because you can't be as present with what do I think? What do I want for my baby? What's my baby needing? What's my baby telling me? Because attunement is such a big part of it.
Huge.
To be honest, one of the hopes we had with our Mindful Beginnings program is to create a little mini version of that, what you just said, like a cohort that's close, that actually talks about deeper things. Because I think that's how people get to that place of trust and connection, is when you're vulnerable.
Yeah.
Right. So if I'm vulnerable, if we're in a group together and I'm vulnerable and you know about like my childhood, my attachment stuff, the things that I'm working through, I feel a little closer to you, right? Because I trusted you with that information, and hopefully vice versa.
Yeah.
And so I think that's one of the, we thought that was one of the things that we're missing. So we're hoping that, you know, helps, but also to not be another voice adding to the mix of, well, you should be doing this and you should be doing that. More about just giving people permission to think about what's just going on for you and what do you need. That's it. You, the parent.
Yeah. And it's a very similar philosophy. So the program that I'm in at UCLA.
Tell us about that program. We're excited to know about it.
Yeah. So it's called the Maternal Mental Health Program at UCLA. So we are a perinatal intensive outpatient program. So it's for women who are experiencing more severe, you know, either perinatal or postpartum depression, anxiety, OCD, you know, different diagnoses, but like just really struggling with their mental health around
it's impacting their function, right?
Yes.
It's to the point where it's impacting their function. I just think I want to make sure to clarify that, because in case someone is listening and they're like, that's what I need.
Yeah. Yeah, it's much more than just like a mommy and me group, right? It's folks who really can't function, or, you know, they can't work, they're really struggling to take care of their babies. They, you know, can't take care of themselves, you know, a lot of different sort of ways that impairment can look.
Maybe feeling like having intrusive thoughts.
But intrusive thoughts can happen to anybody, even without, you know, a mental health diagnosis. I had horrible intrusive thoughts when I had my baby. And the only reason it didn't develop into a full-on disorder was I thankfully had already been doing this work.
Right. So
I knew what it was.
Yeah.
So I would have these horrible, you know, it was images, right? Like intrusive, gory images when I had my baby. And if I did not know what that was,
yes,
I would have been terrified. It would have been an extremely, you know, isolating, an anxiety-producing experience. Thankfully, I knew what it was, and I could just sort of be like, okay, I know what that is. That was a horrible thought, but I'm just going to move on with my day, right? But when it turns into more of a disorder like obsessive-compulsive disorder, that's what we see in our program.
Or if it's not going away.
Not going away.
If you can't shake it.
Yeah. You start avoiding things that, you know, that image or that thought is telling you is scary and dangerous, right? You start avoiding stairs or knives or driving or whatever, what have you, that your brain is telling you is a threat to yourself or your baby. You know, that's a reason that we treat people. But yeah, we have eight women at a time. We're in Westwood at UCLA in person 3 days a week, about 4 hours a day. We want moms to bring their babies, because the babies are part of the treatment, right? It's not just getting better on your own, separate from your role as mother. It's how do you get better within that context and that role and identity.
Yeah. I think that's such an important piece, that women can bring their babies.
Yeah, because there are tons of these types of programs, right? Like you guys run IOPs, right? And there are lots of them around, but not perinatal ones and not ones that are in person and where you can bring your baby. And that can be a barrier to a lot of women in the postpartum getting this level of treatment, 100%. Right?
100%.
Especially if it's an in-person program, but it's just a general depression or general mental health program. That might be great. Like they might get medication management and therapy and skills. Yeah. But if they can't bring their babies and they don't have other childcare.
Right. Well, and attaching to the baby is part of the healing. Yeah. Right.
And sometimes it's, you know, helping them to feel more attached, right? If their illness is helping is making them feel detached,
right?
Or they're scared to attach in some way, right? We can help foster that attachment and that dyad. Sometimes it's kind of the opposite.
Right. It's like too much.
Too much, right? They're really anxious and they can't separate. And so we've had women who come to our program who, you know, their babies might be several months old and they've not spent an hour, 2 hours apart. They don't trust anybody else to take care of them even their partner, their mother, close people that they trust, they just, that anxiety is too intense. And so part of the program for them might be, allowing our staff, I'm going to take your baby just to the other side of the room.
Right.
And you can watch us and you can see us. And then, next week we're going to go just to the room next door. Right. And practicing that graduated separation.
There's a healthy attachment there, right? Because also the baby, this is what we learned in Mindful Beginnings, is the baby understands the mom's anxiety and also feels it. There's something to be afraid of. So then, but doesn't know what. Yeah. And so really, I think helping people understand that is important because no one wants to give their baby anxiety. And it's not like you can just give your baby anxiety. It's more about being the secure base to give your baby security. Yes. Which is the antidote, right? So it's not like you're giving them anxiety, but if you give them security, then they can hopefully handle the discomfort of being away from you and have a secure attachment. Know that you will come back and you will be there and you're consistent. But I think a lot of the times it's our own attachment style that gets either biologically triggered or even just environmentally triggered. Yeah. So I will say that for myself, and I know a lot of women who, the moment you get pregnant and or show, there starts to be all the comments and everything. It starts to just be triggering to whatever it is for your story that happened, right? Yeah. And then the baby comes out, and now all that continues. The comments and everyone has opinions. That's kind of one thing, but this reminder of, well, this happened to me when I was a baby or a kid, or this could have happened, and I don't want this to happen, and I want to be different. It's really loud in there sometimes. Very. And so there's an opportunity, I think, at that point with both parents. I know we're focusing a lot on mom, but I think it's actually about both parents focusing on what does this bring up in you? Like when your baby cries and you can't attend to them or you can't soothe them, what does it mean? Some people say well, that means I'm a terrible parent. Or some people say, well, I'm abandoning them if I don't pick them up every single time they cry. Okay, there's such an extreme between abandoning, right? Yeah. And letting your kid cry. But if that's how it feels for you, we need to look at that. Yeah. Not to change your mind, but just for the adult, mom or dad, to understand what's going on so that they can respond in the way they want to respond today, as opposed to responding to a way that maybe they would have responded in another situation that it's reminding them of. Yeah. Does that make sense?
Absolutely. For me, that brings up so much about especially sleep, infant sleep, yes, and how we think about infant sleep, right? There's so much research on this, on sleep training and what are the things that contribute to infants sleeping longer and better throughout the night, right? And all the research basically agrees that it's parental behaviors, and that parental anxiety, parental over involvement in getting kids to go back to sleep is what contributes to worse sleep. I think in this country especially, we have this idea that, oh, you have a baby, you're not going to sleep for years. Congratulations, right? It's just an automatic assumption that it's like a biological truth. Babies cannot sleep. And it's 100% not true, right? It's our own behaviors and thoughts and assumptions and feelings that are informing how we respond to babies overnight. And that's contributing to how they're sleeping, right? And if we can understand what our own anxieties stuff is, right? Hearing my baby cry, I can't tolerate it even for 10 seconds. I have to soothe them. Otherwise, I'm abandoning them. I'm a horrible mother, a horrible father. And so sleep training, are you crazy? Right. And then I see them 2 years down the line and they're still depressed and anxious because they haven't slept in years.
That doesn't help either. Sleeping doesn't help.
Oh yeah, so that absolutely.
It's a slippery slope. It's just, I do think that, I'm a big fan of attachment. I think when I remember learning about attachment theory in grad school, and I just remember thinking, this is everything. This makes everything make sense. You can place almost every situation into that theory of attachment.
Yeah.
And I really have never changed my mind on that. I work with kids, teens, adults. I've been a parent. I've been a kid. I have parents. Like, secure attachments. And even just like, by the way, it doesn't even have to be with a parental figure. It could be with your partner. Like that was a whole nother thing I learned.
Absolutely.
You can have terrible attachment style as a child and still correct your attachment in your adulthood as long as you have secure attachments with someone.
Yeah.
Anyone who's consistent. So it gives you hope, But what we're talking about, and maybe the people that are listening to us talk right now are maybe newer parents or are trying to be parents or know someone who is. And to me, I would love for people to know this at that point in time. When there's an opportunity there to form really strong and healthy attachments at the beginning.
Yeah. And knowing that strong, healthy attachment doesn't mean never leaving your child.
In fact, it means leaving your child.
Yes. Confidently leaving them in a trusted caregiver's hands.
Yeah.
And being able to project that to your child, like, this is okay. This is safe. I'm coming back.
And I trust that person.
Yes.
And so you can trust that person, right? Because they look to us. I mean, it makes sense, right? They're this little tiny bundle of vulnerability in this world. And of course they look to us to know any cue about anything.
Yeah.
What else are they going to do? We are it for them. We're the litmus test of what's happening here. So if we act like everything is, not act like, but if we truly believe that things are okay, then they're going to truly know that things are okay in their nervous system. But if we're, trying to do all these other things, they have no idea the context of why.
Yeah.
They just know something must be up because, that nervous system is like that. So my nervous system is going to match it because I need to in case I need to survive this thing that's about to happen, which sometimes is not really significant, right? Like to their lives. Like maybe if I'm dealing with something at work and I'm stressed out about it, my baby doesn't know that. They just know that I'm stressed out about something. So the importance of managing our own nervous system is so hard. Like I'm saying these words while also, dealing with it myself. Like I told you, I know all this stuff pretty well. I talk about it all day, but like I was having a really hard time weaning from breastfeeding because of my own stuff. I didn't want to let go of it because of my own journey to get to have my baby. And there's a lot of reasons that I can understand intellectually why I was holding on to it. But last night I understood, I saw something in my child that made me realize this is me being stuck in my own stuff is hurting him.
Yeah.
It's more confusing for him now. So there was a moment of clarity that, again, here I am talking about this stuff, and yet I still am a victim of it. Or maybe victim is not the right word. It still happens to me too.
Yeah.
Like
it doesn't make you immune to it.
Yeah, thank you. That's a better way. That's what I was trying to say. It doesn't make me immune to it.
Yeah.
It still happens. It just happened. And when I had that moment of clarity, I understood it's going to be hard for him. Yeah. He's not going to understand why all of a sudden we're not doing that anymore. But it's going to be way worse if I keep oscillating.
And stretching it.
Yeah.
Yeah.
So again, there was clarity and I feel like a little bit better about it, but it was hard.
Absolutely.
Because of my own projection that came with what that meant, right? Like I was giving him, nutrients and all those things are true. And I was also confusing him.
Yeah.
And making him feel like he can't do it on his own. And so then I watched him, I said, because usually I was nursing him to sleep. That was the last thing we were doing was nursing to sleep. That because when I say wean, we were weaning, but that was the one I wasn't letting go of.
Last one.
Yeah, last one. And he was upset. And then I said, do you want me to sing to you? And he said, yes. Aww. And that was the first time ever that has happened. If I would have asked him, because I know I've asked him in the past, and he just is like, no, don't even bother. You and I both know what I want. Yeah. Let's just do the thing.
Let's beat around the
let's
bush.
go. Yeah. And honestly, I'd be like, yeah, it's gonna work. So let's put him to sleep. So anyway.
And that's the thing that I think so many parents do is like, I know it's gonna work right now. Short term versus long term goals, right? Like
exactly.
You need to go to sleep. I wanna go to sleep.
Yeah.
Let's do it right now because I know this works.
Yeah.
And
100%.
6 months later, you're like, oh shoot, I'm still doing this thing.
That's me. That was me. And the other motivation was, my daughter's asleep, my husband's asleep. I don't want everyone to wake up from this. Like, let's just go to sleep, but we'll just deal with it another day,
Yeah, this is the tomorrow problem.
But last night, what I realized, when he said yes to me, I sang to him a little bit through my tears because I was so sad, but I sang to him. And then I thought he was asleep in my arms. But I was like, let me just check. And I said, do you want me to keep singing? And he nodded. So he wasn't asleep.
Okay.
Which was really good for me because I realized, okay.
But he's calm.
Yeah. Exactly. He's not asleep yet, but he's gonna go to sleep. So then I sang a little bit more, and then I said, do you want me to put you in your bed, in your crib? And he went, so I'm like, okay, this is a new beginning of a new routine that we're gonna need to get into. But he's learning that I'm here, I'm gonna sing to you, I'm checking in, but we're not doing
that anymore.
Yeah. So anyway, I think that what I'm trying to say in telling you this story is that my nervous system calmed down.
Yeah.
He was giving me the reassurance I needed by being able to say, like, yes, keep singing to me. That allowed me to keep going. Yeah. But I think it's a reciprocal thing. And I don't think we give babies enough credit. Sometimes they give us a lot of information, but we have to be listening and watching and asking.
100%. Yeah. We underestimate babies.
Yeah.
A lot.
I did not think he would give me that kind of response, but anyway, we're one day in, so let's.
All right, I'm crossing my fingers for you.
I actually think it won't take long. I think we'll be okay, but it's mostly because I'm in a better headspace.
Yeah.
And so I guess that's what I hope people can hear too, is that we have to take care of ourselves, whether it means taking medication. That's another thing I wanted to touch on.
Yeah.
Is I think a lot of people, including myself, are very hesitant to take medication unnecessarily, quote unquote, is what
quote unquote. Yeah,
that's always my term. Is it necessary? And I know that during pregnancy, especially, every doctor that's not a specialist in pregnancy is afraid of everything that has to do with anyone who's pregnant. At least that's my experience.
It's pretty spot on.
and I get it. And I actually respect it. Like, in one way, like, if you don't know, thank you. Just be cautious on me. Awesome. But send me to someone who does know.
Or look it up, right?
I guess look it up. Yeah.
Because there's so much harm that can be done
by not doing anything.
By not doing anything. Or if somebody is stable, telling them to stop the thing that is stabilizing them.
Yeah. So can you talk about that? Because I think a lot of women are afraid to, once they're pregnant, or afraid to continue their meds or take meds if they need to. Yeah.
So you've put me on my soapbox.
Yeah.
Be prepared.
Do it.
So this is sort of the epitome of everything that I do in my practice, both at UCLA and in my private practice, right? This is the thing that I am most passionate about.
I know. I want to know. That's why I want to hear about it.
This is for the listeners. Like, get ready.
Yeah.
You're going to hear me talk for a minute. Because this is a harm that is done to so many women unnecessarily. And it's done by doctors. It's done by, people in the community who are not in the medical profession. It's done by pharmacists, by nurses, by midwives, by so many different people, right? OBs, psychiatrists, like medical and non-medical people. That there is still this assumption that you cannot take medication when you're pregnant, that it's harmful to the baby in some way, shape, or form, right? Whether the assumption is birth defects or neurodevelopmental disorders is a really, really common fear, right? And that if you if you have a mental illness or a mental health disorder, depression, anxiety, OCD, whatever it is, that it sort of stops at your neck, right? It's just in your head. It's a brain thing. And that, but if you put a medicine into your body, that's going throughout your entire body, right? And that's an assumption that we have to break, because mental health disorders actually do affect your whole body, right?
Right.
And when
including the baby,
right? It creates this entire environmental milieu that the baby is growing in. So how can we possibly think that being depressed or anxious or psychotic or manic or whatever in pregnancy could not affect the baby? And there's also this assumption that we don't have much data or evidence or literature on the meds in pregnancy, or that obviously that data says that it's harmful. And these are assumptions that we have to break, because first of all, we know untreated or undertreated mental illness in pregnancy is associated with preterm labor, preeclampsia, low birth weight, and neurodevelopmental disorders. Like, that's actually what's associated with.
We know that. We have data about that.
We have tons of data that shows us that consistently. And this misconception about meds in pregnancy actually comes from old data that looked at women who take antidepressants, for example, right? Antidepressants in pregnancy. And they compared those women to what's called healthy controls, meaning women who weren't taking the medications, but they weren't depressed. The control group was people who are not depressed. They're, completely
it's
fine.
That's not a 1-to-1.
It's apples and oranges. It's not even fruit. It's apples and cell phones.
Vegetables.
Yeah. And cell phones. And so the old data, it showed people who take antidepressants in pregnancy have associations with these bad outcomes.
Oh man.
And that's where so much of this misconception comes from. So brilliant researchers figured out that, we need to do these studies again, but look at an actual control group that makes sense. Mm-hmm. And when you control for the underlying depression, right? When you compare women with depression untreated versus women with depression who are treated, the association of all these bad outcomes with the medications completely disappears, basically.
Wow.
So it's not the meds. It's the underlying mental illness. So actually taking somebody off their meds. Yeah.
It's the illness that's the issue.
It's the illness.
Oh
so taking somebody off their meds, like you said, it's really well-intentioned, right? These doctors don't want to cause harm.
Yeah. No one wants to be responsible for someone else, someone else's baby having an issue. And how you just put it, I've never heard it said like that before. But that's so clear. That makes so much sense.
That felt very sciencey to me, so I'm glad that was
that's
clear.
Like, well, if I think the science just seems like it was off.
It completely was. And so again, we have groups of really amazing researchers now who are looking at, all the different classes of medications that we have and doing this type of research, controlling for underlying, confounding variables. And again and again, there may be still some medications that there's a slightly increased risk of one specific outcome.
And anybody about it, right? If you know about it, then you weigh the risk on that situation.
That specific situation. But you can't generalize that all meds in pregnancy.
Right. Is it, okay, let me ask you a question. Is it like someone who has, let's say, diabetes, and they have to take medication to control their sugar and to manage all that, right? Their glucose levels. Then to just say, okay, but don't take it during pregnancy.
Yeah.
But then the crazy glucose levels is going to affect the baby. Mm-hmm. So, right? Is that like a similar
very much
analogy?
So. Yeah, and I actually love that analogy because people don't think about, they don't second guess, I have to, take my blood pressure medication or my diabetes medication or, things to treat physical health maladies.
Right.
They don't second guess that. When it's mental health, it's, I should be able to muscle through.
Yeah, because of the stigma,
Because of the stigma. And, there's also, certain misconceptions like, oh, but if I'm taking an SSRI, serotonin reuptake inhibitor, then if I'm taking that during pregnancy, my baby's brain will not ever learn how to make serotonin. It's just not true. They learn it develops normally.
But the fact is that the mom's body will not be producing serotonin in
the same way, and mom will suffer.
Yeah,
and
which will affect
baby. Yeah, and for some reason, people they don't question being depressed or anxious during pregnancy so much. They kind of think about it's muscling through, but people are very concerned about postpartum depression. That I think that diagnosis is present a lot more in sort of the ether, right? People are really afraid of postpartum depression.
Or maybe you can manage your depression, like ish, but then when it's postpartum, it's like off the charts.
Yeah.
And so then it becomes more of like let me take care of this.
Exactly. And so people who come to see me either when they're pregnant or before pregnancy, they may not necessarily be coming to see me because they want to treat their depression right then.
Right, but they're anticipating it.
But they want to prevent postpartum depression. That's the thing that they're really, really concerned about. And the conversation that I have with all of them is that, yes, absolutely. Let's get on top of that. Let's prevent this as much as possible. What's the biggest risk factor for postpartum depression is depression during pregnancy. Active depression during pregnancy.
Oh, okay. Really? I didn't know that.
Yeah. So the biggest, most impactful thing that someone can do to prevent postpartum depression, if they're already depressed or they have a history of it, is to continue whatever medication regimen that they're on during their pregnancy.
Is that the same for anxiety?
Same for anxiety, same for kind of
OCD,
everything.
anything. Yeah. I mean, that makes sense. Again, you say it and it's like, that sounds very logical, but why is that not common knowledge? Also, I don't know. But I have a question. It's going to take us a little bit side tangent.
Yeah.
What are your thoughts about TMS?
It's a really effective treatment. It's being studied for postpartum depression currently, but it's a good, effective treatment. It can be used in pregnancy. Just from like a coverage perspective.
Yeah.
It's right now it's kind of covered, I think, only for treatment-resistant depression.
Yes.
It's not like something that you can just go to immediately. And just for context, TMS is transcranial magnetic stimulation. It's a type of interventional treatment where you kind of go to a TMS center, you sit in a nice comfy chair in a nice dark room with spa music playing, you put on this helmet, and it turns on magnets basically at specific points on your head that stimulates your brain, and that's a treatment that we have for depression. So it's not a medication.
Yeah.
And so
that's why I ask, because I just wondered what your thoughts were that versus medication. But it sounds like it just again depends on, is it treatment resistant?
Is it treatment resistant? How accessible is it for you? Is your insurance going to cover it? Because if insurance doesn't cover it, it's quite expensive.
Sure. Yeah. So similar to what the other stuff we were talking about. Like if you were doing TMS before, then keep doing TMS. Or if you were doing whatever it was, continue to do. And yeah, I see, like, I feel like a professional like yourself really understands the nuances, and I would trust if you told me like, okay, don't take that during pregnancy or don't do that during pregnancy, then I would trust that it's because I shouldn't do it during pregnancy versus like, just a blanket statement that, we're going to be conservative and just assume we can't do it.
Yeah. But I think, and that's why I this is such a soapbox for me. It's not just about finding a specialist. I think this is knowledge that needs to be, core competencies for every doctor. Every doctor should be keeping up to date on data about things in pregnancy, even like the basics, right? You don't have to know the data on every single medication, but to know like, okay, any SSRI is fine in pregnancy, right? Another really common thing that I see is doctors saying, okay, fine, we can treat your depression in pregnancy if we really have to, but you're on Lexapro, we got to switch you to Zoloft. Zoloft is the safest medicine in pregnancy.
But now we're changing meds.
Now you're changing meds, and you're changing meds off of one that works great for this person and has the exact same safety data as this other one. And so it's really
So you're just putting the body through something when it that doesn't need to happen.
Doesn't need to happen. And again, you don't need to know the data on every single medication, but to just know like the basic, any SSRI is fine. Don't switch.
Right.
That.
Right. That's enough information.
Yeah.
Well, I hope that they start to, I don't know how maybe OBs or.
I mean, I'm hoping that it's becoming more integrated into, residency programs and medical education, right? I do the lectures for UCLA residents on this topic. And, one of the things that I just try to hammer home, because again, not every psychiatrist knows this, right? People who graduate psychiatry residency from really prestigious institutions don't know this information, and they make these same mistakes.
Do you think it also matters when they went to med school? Like
partially,
the older data, right?
Yeah, partially. I mean, there are some older psychiatrists who really are good on staying on top of the data.
That's true. You're right.
And if it's really actually concerning if you look at data about, residency programs and who has women's mental health experts or specialists, like if they even have access to somebody who has this knowledge, who is teaching them this knowledge or not. And so there are a lot of people who are graduating residency
like right now
who don't know this.
Okay, so you're going to change that, right? You're going to teach everybody.
I'm trying my damnedest.
Okay, good. And maybe people who are listening today will learn this and it'll get to the right hands.
Hopefully. One thing I just want to add, because it's a really common question is, okay, so we talked about meds and pregnancy ad nauseum. What about breastfeeding?
Yes.
Basically anything you take during pregnancy, you can take during breastfeeding. The exposure amount through placenta is about 5 to 10 times higher than it is through breast milk. So if you took something during pregnancy,
you can take it.
Take it. Just continue it.
Yeah. To be honest, I was telling you about my breastfeeding journey, and I actually this morning thought, what are all the things that I haven't been doing that I can be doing now?
Yeah.
That I'm not breastfeeding, and honestly, the list wasn't long. But it has somehow felt like it was such a but I'm breastfeeding.
Yeah.
Like we just had, and it really comes from a lack of knowledge. Honestly, it does come from a lack of knowledge. Mm-hmm. We just had the flu pretty bad in our house. It was brutal.
I'm so sorry.
And I felt like I was cautious and scared of what I could take because I was breastfeeding.
Yeah.
And, you got the internet, you got ChatGPT consulting with you, which is not a doctor, so that does not count. But that's what I had.
That's what everybody has now.
Yeah. In the middle of the night, just trying to understand, like, I have these fevers and these chills, like which over the counter thing in my cabinet am I going to take? It's stressful. Like, it doesn't need to be. So I wish, like, we had this conversation 2 weeks ago.
Yeah.
And I would have this knowledge, so I could feel more comfortable. But
when it comes to questions about breastfeeding and what you can take and what you can do in breastfeeding, I always recommend that people also just check with their child's pediatrician. Because if you think about, like, the pediatrician is going to be thinking about the things that the child is eating and consuming. Yeah. And so if the pediatrician knows, okay, they're still breastfeeding, but they're getting exposed to whatever in breast milk, that's an excellent resource. And most people can get a hold of their pediatrician fairly quickly.
Good point. I wish I would have thought about that too, instead of just suffering through that fever. That was a little. I mean, I ended up taking. It was fine, but for the first night, I didn't because I wasn't. I didn't think to even, like, learn about it. I just was like, oh, it's going to be over in the morning.
Yeah,
and it wasn't. So.
And that I think also is a opening to say, and I realize that this medicine is not a psychiatric medicine, but I've talked about this in the past. If you have a fever and you're pregnant, it's extremely harmful, and you can and should take Tylenol. It does,
because the fever is more
dangerous is more dangerous than Tylenol. Also called acetaminophen. In European countries, it's paracetamol. There was a big controversy, hullabaloo a few months ago, with people in positions of authority and power advising people to not take Tylenol when they're pregnant because of the risk of autism or other neurodevelopmental delays. So it wasn't true then. There was even just a study that was published, I think it was like last week or 2 weeks ago, giant study that again, disproved that. So if you have a fever, you have the flu, you're breastfeeding, you're pregnant, you can take Tylenol and not suffer.
Yeah, no. I was like every 4 to 6 hours I was taking it because it was bad. But like I said, the first night I just, this is also part of this martyrdom that comes with like, I'm going to be fine. It's going to be fine. And then it wasn't. And I will say I've never been more appreciative of Advil and Tylenol in my entire life. Yeah. Last week it was like literally on the clock, just taking it every couple hours for myself and my kids because we were struggling. Yeah. So, and I think that's important to remember that the actual fever itself is what's dangerous.
That's what's dangerous.
Yeah.
And that being a martyr does not serve you or your children.
No, it really doesn't. May I learn that one day. But I'm still learning.
May we all learn
I'm still learning that one. I'm still learning that one. And I hope to be done with that. But it's really hard. Yeah. I think it's ingrained in me in some really deep kind of way. Mm-hmm. And I know I'm not alone in this. I know that there's a lot of people out there that, for whatever, all our reasons, like we all have good reasons for it. Yeah. And yet those reasons don't need to still exist today. So yeah. Thanks for the reminder. I'm appreciative. Excuse me. I'm appreciative of this conversation, and I'm trying to think of what else. There's so much to talk about. I'm trying to think if there's anything else that comes across your desk or you think is like a misconception about any of these topics. Yeah. We've hit a couple.
We definitely covered some of the big ones, right? That mental illness during pregnancy or postpartum is much more harmful than taking meds. If you're on a medicine that is working well, you don't need to switch to especially, specifically Zoloft. Nothing against Zoloft. Love Zoloft. If that's what works for you, right? If that's the thing that you're on that's working for you, great, stay on it. But that's, I think, one of the most common misconceptions that I see is that it's safer or the safest antidepressant to take.
I think people just know about it more. More doctors are familiar with it, so they're more comfortable with it.
Yes.
Even like a layperson, everyone knows what Zoloft is. Yeah. They don't know all the names of all the other medicines, so it feels foreign. And it comes from this piece of data that it has the lowest transmission through the placenta. So it's sort of like technically that's where it comes from. It's the lowest exposure, but all of the other ones have, marginally higher exposures, like tiny, tiny, tiny amounts, and the safety outcomes are not different. So so that's assuming that the exposure increases any kind of safety outcome. But if it doesn't, risk. Then
so that's why it's not the safest. And actually, switching is gonna
there's more risk there because then if it doesn't work, then you have to go. Now you're making this baby work on all these other things versus just staying steady.
And I think about that all the time, right? Like if Zoloft worked for everybody,
then we'd all take it.
We wouldn't need any of these other meds. We should just start everybody on Zoloft. But we don't.
Excellent point. I never thought of that.
Why do we think it's going to work for every single pregnant woman?
Because that would be easier.
Yes.
That would be easier, but that's not where we're at.
Yeah. I think one other thing that I would want to touch on is this other thing that kind of gets thrown around on the internet and from pharmacists and people, that if you take a medicine, an antidepressant during pregnancy, that the baby will go through withdrawal or it can also be worded as are going to have a higher chance of a NICU admission. And that's
no one wants to hear that.
That's a very scary thing to hear.
Yeah.
And this is something that I talk about all the time with my patients who are considering staying on meds in pregnancy is, what is this even talking about? It's talking about this thing called neonatal adaptation syndrome, which is something that is associated with people who take antidepressants in pregnancy. We don't know that it's actually a withdrawal. There's a study that really sheds a lot of doubt on that, where they thought, okay, well, if it's a withdrawal, let's stop the medicine for the whole third trimester, right? It's enough time to wash out completely, and we shouldn't see this at all in the babies. Happened with the same frequency. So it might be another example of something that's associated with, again, underlying mental health disorder versus the medication. So we don't know exactly, but it is basically this very short-term, transient difficulty with adapting to outside life right after delivery.
Okay.
So it could look like a whole number of things. It could be crying. Their muscle tone might look a little off. Either they might be a little bit floppy, or they might be a little bit more rigid or tense. They might have difficulty with suckling or latching initially. If you think about newborns, if you've ever been around a newborn, all of them look like this, right? All of them look like this. And so if you look in the literature, it's like up to 30% of babies might experience this. There's no way, 30% of babies who are exposed to these meds in pregnancy are not getting diagnosed with this. What the ones that do end up getting diagnosed or recognized or who need some extra support are the ones who, at the most severe end of this, again, if they have difficulty with latching or suckling at the beginning, they may not be able to feed initially. And some of them
Which would result in some of those symptoms.
And some of them may not cry right off the bat, or they might have some difficulty with maintaining their oxygen level. And so it's that very, 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 very small subset that might need some support with feeding and with like oxygen, right? Where does that happen in a hospital? Almost always in a NICU, right? That's not going to happen on the regular postpartum unit. It's not going to happen typically in a normal, like a regular peds or pediatrics floor. Typically when a neonate, right after delivery needs any kind of support, it happens in the NICU. What that, increased rate of NICU admissions doesn't say is it's for like a few hours or a day at the most. And they don't need anything to make this go away. They don't need medication. They don't need anything else. It's just
extra support,
right? A little like baby oxygen thing and some feeding for a few hours. And then long-term studies have shown that they're totally fine, happy, healthy, normal kids, everything else being what it needs to be, right? But that this does not affect them long-term. And so I talk about this to this extent with my patients because I think it's really important to dispel this misinformation. Because to just say, to whittle that down to increased NICU admissions and withdrawal is horribly scary.
Well, what I appreciate about you, Brittany, is that you take that information and you explain what it means. Like what you just said, if I was about to have a baby and you told me that would feel very different. Then I can make my own decision about what I'm comfortable with, right?
Yeah.
But you just explained what is it, like the warning labels or whatever. You explained what that means.
Yeah.
Which is so important, I think, to me, at least, as a patient, as a mom, honestly, as a caregiver in this community. Like, that's what I seek when I refer to somebody, is somebody who can do what you just did, which is explain what that means.
Yeah.
Because it does sound scary. I just said it. I was like, I don't want my kid to be admitted to the NICU.
NICU? Oh, God,
But then when you explained it right now.
Yeah.
It just feels very different to hear that a kid needing to go to the NICU because that's where these things are is very different than you hear NICU and you hear life and death,
Absolutely.
And that's and maybe without the oxygen and without that extra support, it's risky. But what you just described was very different than like the warning label makes you feel.
Definitely.
Meaning, I should say, no, it's not that it's that different. You said exactly the same thing. You just said more.
Yeah.
You took the time to understand what it means enough to then explain it to me. And that's what I really appreciate. And I think it makes the difference for people to really feel taken care of. I
appreciate that.
Yeah,
that's the goal.
It's true. I just wish there was more doctors that did that. So I hope that there are. I hope we continue to have more, use that more information that we have and use it to help educate and inform people.
I think that's what people need, right? We're living in an age where all of this information is more accessible than ever before. But how do you parse through it? How do you interpret it? How do you weigh, okay, so risk of untreated mental illness, medication, withdrawal, NICU, like how do you combine all of this into one sort of clear picture and to take that and then make a decision about what you want to do.
Exactly.
Right?
Based on your factors, and to have somebody to talk it through. And you said it in layman's terms. Like you were using so much jargon that it lost me. Like I followed you. I followed you. I could imagine the whole thing. I was playing it out like in the hospital with how scary it already is to have a new baby, no matter what is going on, which is true. I mean, the moment they come out, you're like, all the questions. Is everything okay? Yeah. And honestly, I think for the rest of their lives and yours probably, but the first few weeks I would say are just so scary anyways, no matter what.
Yeah.
So add any factor to it and it just sometimes feels very overwhelming. So this comes back down, I think, to taking care of the moms and the dads and giving them the knowledge to then make the decision that feels right for them, which is kind of the point.
It's the whole point.
Oh man, we could talk forever. I feel like there's always more, but this was so helpful. I learned so much even today.
Thank you for having me again.
Yeah.
I know I got on my soapbox. This is the thing that I could talk forever about.
That's why you're here. And that's why, seriously, that's why you're here. So that more people can hear about your soapbox and know about you and hear your style and maybe reach out to you if they're thinking about like, gosh, I just wish I knew you before I knew you the way, like professionally.
Yeah.
I think you could have probably really helped me when I was, especially my first pregnancy. But anyway, I know you now, and hopefully there's other women out there that are getting support from you that need it.
Hopefully.
So, and good luck on your journey.
Thank you.
I am so happy for you and proud and can't wait to see this little list. Is it a girl or boy? I don't remember.
It's a girl.
See, that's another question people ask, and I just did it too. Like people ask as if it matters. Like it really doesn't matter as long as they're a healthy little human being.
Little human being, exactly.
Yeah. I guess in my mind, and I think this is what people do, is they want to sort of imagine, like put more information to the picture. But anyway, thank you so much for being here, and I'm sure we'll do it again.
Yeah.
Take care.
You too.
Bye. Bye. Hi.